Morning, everyone. Welcome to the Halloween edition of Medicine Grand Rounds. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous people, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enhance our vibrant community. Dr. Kassam is away today. I'm Jennifer Ringrose, the Divisional Director for General Internal Medicine, and it's my great pleasure to introduce Dr. Greg Hrynchyshyn, who is a GIM colleague, a clinical professor in the Department of Medicine, and has been practicing general internal medicine since August of 1998. He has held leadership roles as a site department lead and facility medical director at the Grey Nuns Hospital, and has sat on the MFAC committee of the CPSA. Dr. Hrynchyshyn is currently the medical director of the Edmonton Zone Virtual Home Hospital and has been in that role since February of 2019. So please join me in welcoming Dr. Hrynchyshyn.
Thank you very much, Dr. Ringrose. And thank you very much for allowing me to present today about work that kind of resonates with me and I still continue to be passionate about after the last 6 years of being in this role. And I hope it will resonate with you at the end of my talk. So my discussion is going to be about the Edmonton Zone Virtual Home Hospital program and how we perceive that we're starting to transform acute care in the home environment. I'll start with my disclosures. I've had relationships with some financial sponsors. I've done some consulting work for some pharmaceutical organizations, usually in the context of diabetes. A large part of my outpatient practice is diabetes. I've been a contracted medical leader for Alberta Health Services and for Covenant Health in the past. I would say financially, our program is sponsored by AHS, so we receive direct financial support from the organization. You could argue that I have a conflict of interest as the medical director, that as I'm a contracted medical leader for Alberta Health Services, and I'm invested in the success of the program in that aspect. So perhaps my view is different. So I wanted to start with an overview, I guess, of what I'm going to talk about today. And I want to start initially with a patient story that I suspect will be familiar to all of you in clinical practice in this room. I want to talk a little bit about the history and evidence of home hospital care. I'd like to talk a little bit about our origin story, some specifics about our model of care, and the impact that we've been able to achieve over the last number of years. And then in addition, I want to talk about what's in it for you in terms of working with the virtual home hospital, how to consult, and what does the future potentially kind of hold for us in home hospital care. So I'm going to start with a patient story. And if you do clinical medicine in the Edmonton area, this will resonate with you significantly. This is Mrs. A. She's a 78-year-old woman. She has a past history of known congestive heart failure, type 2 diabetes. She has hypertension. Despite her comorbid conditions and chronic medical issues, she lives independently in the community with her spouse, and she presents to the acute care environment with acute fluid overload, and she receives a diagnosis of decompensated heart failure. And in hospital, she has mild hypoxia. She's, let's say, on 3 to 4 liters of oxygen on presentation. She's dyspneic with any activity. And as expected, she's consulted to be admitted to hospital. And let's say she's admitted under the General Internal Medicine Service at this time. She starts off on her O2. She's requiring intravenous diuretic support. And over the next kind of 1 to 2 days, she starts to improve. She's getting better. She's being able to be weaned weaned from supplemental oxygen. She starts to be able to transition to oral diuretic regimen. There starts to be a process of readdressing her goal-directed medical therapies for her heart failure. And she's seen by physio and OT, given her limited mobility and endurance, and they start to clear her potentially for discharge. she's kind of getting close to her quote unquote dry weight. And at that time, there's a lot of discussions about discharge. And so she has an appointment that's booked with her primary care physician. A referral is made to the heart function clinic, and she's fairly nervous to go home. She perceives herself as not being ready. She has anxiety. She's been in emerge a number of times over the last several months, just with symptoms of volume overload, but never admitted other than this time. And so you've kind of arranged for follow-up with the PCP, and your referral is placed to the outpatient heart function clinic. And your team recognizes that she's fairly high risk for readmission. Her LACE score is 12. Her first available appointment with her primary care practitioner is probably about 3 weeks from now. And that's not a surprising, and I would say, occurrence in Edmonton at this time, given the burden that exists in primary care and our primary care colleagues. She's been accepted to be seen at the heart function clinic, but her appointment is still pending. So you acknowledge and recognize that she's a high rate risk patient for readmission to hospital. And so a consult is sent to the virtual home hospital. And at this point in time, I'm just going to put her story on pause for a moment, and we'll come back to it. So Mrs. A is, I would say, a very common patient in our healthcare system. And some people would articulate that she fits into a kind of a high cost user of healthcare. And as time goes on, as all of us kind of age and accumulate more, I would say, chronic disease states and comorbid conditions, as we come to the last kind of months or years of our life, our need for reliance on the healthcare system increases. And we will eventually, most of us, become high system users of healthcare as time goes on. And the estimates are that about 5% of the population accounts for about 60 to 65% of total healthcare spending. And a large component of those cost drivers are ED visits and inpatient admissions. And that's very often, it's the typical diagnoses that are seen in every, I would say, acute care institution across this province. The top 5 diagnoses are heart failure, chronic obstructive pulmonary disease, pneumonia, acute coronary events, and hip fracture. And hospitalization, all of you who work in hospitals recognize that hospitalization is not a benign event. There are significant risks for older adults in particular. There is an increased risk of discharge to long-term care with hospitalization. Some of that may be inherent with the fact that people become significantly deconditioned in the context of an acute care hospital stay. There's an increased risk of more mortality associated with hospitalization. That's not a surprise. People are sick when they come to hospital. A significant increase in the incidence of delirium and cognitive dysfunction, and that potentially, we know now, may set up patients for longer-term cognitive dysfunction, is suggestive in the literature at this point in time. And so that kind of leads us to the opportunity for, I would say, a hospital at home or hospital at home care. And this isn't a new concept, hospital at home. And really, the historical definition of the hospital at home model really started probably in the early 90s, for the most part, around with the Hopkins group in Baltimore. And the idea was to basically provide acute care for patients in the context of their own home, with the following kind of characteristics that they had to have: that they required an inpatient admission stay. They needed to be medically and functionally appropriate to be cared for in their own home environment. There may or may not be a caregiver in place with them. And the idea was to utilize existing resources that the organization could bring to bear for those patients. And the idea was to focus on admission avoidance or early facilitated discharge. So the idea in terms of admission avoidance was to take these patients directly from the emergency department, or the initial presenting environment, and prevent them from ever seeing a hospital ward. The early facilitated discharge kind of area was to identify patients potentially within the first 24 hours and transition directly to a home hospital model. Over the last, I would say, 5 years, there's certainly been an explosion of interest in home hospital care. And there is a World Hospital at Home community that has come up with an international definition of hospital at home. And they define it as an acute clinical service that takes staff, equipment, technologies, medication, and skills often provided in hospitals and delivers that hospital care to selected people in their homes or in nursing homes. It substitutes for an acute hospital care. What it isn't, and that's important to recognize, is that it's not home care. It's not solely virtual care. It's not solely chronic disease prevention and management. And it's certainly not a replacement for robust primary care medicine. The concept of caring for patients at home is not a new one. And in fact, when you look back historically in the 30s and 40s, typically about 40% of all healthcare interactions in North America were delivered at patients' home. And that's partly in the context of the fact that hospitals have not matured to the I would say the infrastructure maturity and the complexity of technological innovation that we actually have at this time. And so a large component of care could be provided at home. France initially formalized a model in the 1950s, and Johns Hopkins, as I said, piloted the model in 1995 and showed significant cost savings with the patient population that they suggested. And during 2010 to 2020, there was a lot of interest in kind of hospital at home. There were pilot initiatives in the United Kingdom, in Australia, in Canada. And as we moved into the 2020s and beyond, with the advent of the pandemic, the pandemic really served as an accelerant for home-based care and hospital-at-home care. And the pandemic, for all of us, as you know, was an accelerant for many things in the healthcare system. But for hospital at home, it really served to be a mechanism whereby this was thought of as a significant opportunity to care for patients. So looking at the current kind of environment of hospital at home in Canada, there's really, I would say, hospital at home environments or hospital at home care models across the country. I know that there are more being piloted and struck up in the Maritimes at this point in time. I know that Newfoundland has one and that they're wanting to bring to fruition or bring to commencement. I would say that we in Alberta have had the luxury of developing two programs, ours in the Edmonton zone, and we're one of the largest. We have approximately 90 beds over a number of services. We've been the first to launch a surgical, I would say, ward or arm to our home hospital. Calgary has two sites. They actually have the Rocky View and South Health campus that have a hospital at home model. But this has led to the formation of a 2024 hospital at home working group, and we are starting to meet regularly to kind of develop and I would say understand the opportunities for hospital at home care across the country. It's important to recognize that hospital at home has had an international impact, and I would say that spending more in healthcare wouldn't be a problematic if it were associated with better outcomes for patients, better outcomes for the system. There's a wide body of literature that suggests that hospital at home interventions show benefit in all aspects of the quadruple aim of healthcare. Better patient outcomes, efficient resource utilization, cost effectiveness, better patient and caregiver satisfaction. So from an outcome perspective, there's very good literature that there's a reduction in mortality in terms of an NNT of 50 to save one life. If you admit, I would say, case-matched patients to a bricks and mortar hospital versus a hospital at home environment. There's certainly a reduction in the functional decline burden that occurs with patients in a hospital at home model. There's a likelihood of less iatrogenic complications. We tend to see a reduction in length of stay, a reduction in readmissions. Some of that, there's a reduction in unnecessary testing, partly because of let's say, the logistical difficulties associated with testing. There seems to be a cohort of cost effectiveness and cost savings with most home hospital models. And surveying patients and caregivers, for the most part, satisfaction tends to increase for them. There's less anxiety, there's less upheaval in their typical day-to-day lives, less depression as well in response to a hospital and home model. most of us will like being at home and like have our routines at home, and patients are no different. And so I think it's important to acknowledge really kind of the burden of evidentiary benefit that exists with hospital at home models. Looking at our origin story for hospital at home, um, this work started far beyond or far before I actually took the role on. Really, it would have been in, I think, 2015, 2016 that the Department of Medicine undertook a review of I would say, high cost users in healthcare who were coming in and out of hospital on a routine basis. And what were some of the drivers that resulted in those patients coming back again to care in a that led to the concept of potentially a home hospital model piloted here at the University of Alberta Hospital. And that work was led by Dr. Kassam and Natalie McMurtry, who really took a lot of initiative to try to obtain funding and worked with the Enhancing Care in the Community project at that time. And so they were able to actually convince people to come on this journey with them and support it. In 2018, we started kind of the idea of a home hospital model with an innovation lab that developed a new model of care for high system users of healthcare. It targeted patients who had 3 or more ED visits or admissions in the past 365 days, not 265 days, forgive the typo. And the focus of those patients was admission avoidance, trying to keep them from coming back to the acute care environment if possible. It was an iterative model. The idea was to use PDSA cycle and be based on the quadruple aim principles of healthcare. We worked with the virtual health team at that time to incorporate Skype for Business so that we could do virtual patient assessments, and started really with the goal of 30 medicine beds. It's important to recognize that we kind of tried to focus on the right care model, and we searched for a lot of different opportunities in terms of hospital at home models. And if you look at kind of the different models that we reviewed, there's the UK had a longstanding kind of hospital home or primary care based virtual ward that was really based on populations of patients, and they identified in a cohort of a large number of outpatient population those patients who were at highest risk for hospitalization, and sought to potentially manage them into a different model of care, working with their primary care practitioner largely. There was the virtual ward concept in Toronto in 2014. That was a bit different. It recognized patients who were high risk, but again, those individuals would have been, I would have stated, the best way I can describe it is that they were recognized to be high risk. They were rounded on by a multidisciplinary team, but they didn't necessarily have a physician directly caring for them. The interaction was basically with the patient's primary care physician to assist with kind of changing care. And there were significant, I would say, logistical delays in how that was able to occur. And so there was an opportunity lost with the being able to provide an immediacy of care for patients in the context of deterioration at home. The Singapore virtual ward kind of probably resonates closely with us in some aspects, in that they actually had identified a model of care that really was front loaded with patients coming out of the acute care environment. That they received really aggressive supports within the first several days coming out of hospital, still partnered with primary care, but had a lot more of that initial upfront I would say, navigation and stabilization in the initial period of time post-discharge. And then we've already commented on the traditional hospital at home model. And we probably span somewhere in between the traditional hospital at home and some of the, to some degree, maybe the Singapore model, probably best. And we've had significant growth and evolution. We've been very lucky. And also, we've partly made our own luck and recognized opportunities for ourselves. As I said, in 2018, we launched with our 30 virtual medicine beds, and our initial focus was on high system users of healthcare. In 2019, we recognized that Calgary was undertaking a similar initiative, and really started to collaborate with our colleagues in Calgary. Dr. Michelle Grinman, who's a general internist down in the Calgary zone, was leading the team at that time. And really, we started to share with each other the different patient populations that we could care for in a medicine environment, and started to focus more or incorporate those admission avoidance and decreasing acute care length of stay patients. In 2020, we were able to participate in a McMaster study, the PVC RAM surgical study that randomized patients to receive home, I would say virtual home hospital care postoperatively. And those were patients who had unplanned surgeries, so urgent or emergent surgical intervention. And that led to us kind of wanting to basically dip our toe in the surgical population and expand it to 15 beds at that time. In 2021, in the context of the pandemic, we were able to leverage to get an additional 15 surgical beds. And then in 2022, we started to participate with other teams. Cardiology started to be very interested in how they might be able to utilize a home hospital model. We've had colleagues in women's health recognizing the burden that they deal with in peripartum hypertension. And really were interested in partnering with us in that context about how they might care for young mums in a very different fashion than they were doing previously. And so we've been able to open an additional 15 virtual beds in 2023. We've started to pilot some work with neurosciences. And then in 24-25, we've really continued to try to expand, I would say, really establish relationships and expand our partnerships with other care providers. We've worked with colorectal to have a day case conversion. We've established a HealthLink partnership for after-hours coverage. We looked to expand cardiology. We hired ambassadors to try to, I would say, assist in spreading our message of home hospital care. And more recently, we've done some work with the bariatric surgery program to convert their patients to potential day cases. And we are looking at 90 beds at this point in time. So our goals really consist of the following. We want to try to decrease a bricks and mortar inpatient length of stay. We want to prevent and reduce ED visits and readmissions to the acute care environment. We would like to try to increase patient and family and provider satisfaction with the care that's delivered in patients as they transition out of an acute care or bricks and mortar environment. So what exactly do we do? What is the virtual home hospital? So I would say that we're a team, and all healthcare really is delivered in a team fashion. And it provides, hospital level care to patients who remain safely in the comforts of their own home. These are technically our hours of operation, 7 days a week, 8 a.m. to 8 p.m. We have someone that's readily available to talk to any patient or family in that aspect. It's a multidisciplinary team. We have nursing, pharmacy, unit clerk support. We also have an NP team that assists in the care of patients. Currently, right now, we have approximately 25 patients on that work with us throughout the Edmonton zone in varying specialties. I think it may be a little more right now with the expansion that we've had in women's health. Our medicine specialists include GIM physicians, pulmonologists, cardiologists who work with us at this time. We try to use technology that's integrated. So the virtual health team at the time, in the context of the pandemic, there was an intent to try to basically develop or leverage the acquisition of physiological monitoring for patients at home and how we might use that. And so we partner with, the organization basically has purchased or has a contract with a Canadian company, CloudDX, that basically provides physiologic monitoring kits that allow you to check your weight, your blood pressure. It allows you to check your blood pressure, your weight, your oxygen saturations, and that information is integrated into the Connect Care environment at this time. And so really, we direct patients to do their vital signs. Then our team can see them. We can identify trends in weight, identify trends in blood pressure. And so that requires patients to be engaged in their own healthcare. And then we have field teams. We basically have partnered with our colleagues in lab to get our patients registered on home collections when they're under our care so that they can actually get home collections in a timely fashion. We have, I would say, our physician avatars, the community paramedic team that really go out and provide care in the community as I would say, as the hands and feet and the eyes, and liaise with the physicians who are working in the virtual hospital. And then we utilize home care where and when we can as well for the provision of care. So the idea is to align with these other groups and really have an expansive team that coordinates care for patients. So who do we serve at this time? So from a medical medicine perspective, really we take patients from multiple areas. We take them from the general internal medicine service, pulmonary ward, cardiology. We take patients occasionally from the emergency department directly, from the family medicine teams, from neurology. Surgery, we as I said, this is a surgery talk, but we've partnered with general surgery, urology, bariatrics, ortho. We provide enhanced surgical monitoring to patients who are deemed to be high risk post-discharge from hospital. And then the women's health, we've been doing some interesting work with postpartum hypertension management. General criteria for admission, we're an adult program, so our patients need to be 18 years or older. They need to be able to stay within the Edmonton area, and that's within about 80 kilometers of the Edmonton area in terms of the reach that we have with our community paramedic teams to go out and see those patients. We need them or their caregivers to be able to provide informed consent. They need to be able to complete their acute care stay at home rather than leaving the province, for example. We want them to be functionally safe at home, and they need to be able to communicate with us by phone or computer. We need them to be able to be engaged in their own healthcare and being able to follow instructions. We can support patients who have cognitive dysfunction, provided there's, I would say, a willing caregiver who's wanting to partner with us to provide care. And so that I think is an important kind of provision. So typically, who do we accept? We'll take patients who require short-term monitoring, management of acute issues following the ED visit, or regular early discharge from hospital. We want to try to bridge them to the primary care physician in the community or to their outpatient specialist management kind of teams in that context. So as I said, our focus is, how can we shorten an inpatient length of stay? Are we able to avoid admission for someone who's actually at high risk for coming back? Can we actually provide enhanced monitoring or medication management to facilitate them and preventing them from bouncing back even to the acute care environment in any capacity? So if you look at kind of some of the logistically kind of and the reality of some of that is patients that we think benefit the best from our care are individuals who've had probably 2 or more interactions with the acute care health system in the last 6 months. And that can be ED visits or inpatient admissions as a possibility. We focus on LACE scores 10 or more, tend to be high risk for representation. And oftentimes we can take patients who require further medical management in the context of waiting transition to an outpatient arm as well. In terms of kind of the GIM and cardiology arms that are most relevant to you folks, I would say, we can take patients who require IV antibiotics, but really aren't good candidates for outpatient IV therapy clinics or for the home IV program. We see a significant component of heart failure patients or volume overload in that aspect as well. We've been able to take patients with blood pressure management issues, autonomic dysfunction patients. We've been able to take patients who actually have hypertensive urgencies or emergencies in that aspect. We take patients with acute kidney injury that are in the process of slow recovery. There's a significant literature that supports patients who, with about half of COPD exacerbations, might benefit and might be readily cared for in a home hospital environment rather than admitted to an acute care hospital. We often take newly diagnosed patients with diabetes and are able to bridge them out of hospital sooner and transition them to some insulin stability while they're waiting for outpatient optimal management. In the pandemic, we pivoted a lot to see how we could serve the COVID population. And I would say as time, and we still continue to be able to provide IV remdesivir where need be. And then the cardiologists themselves kind of look at basically a lot of rate arrhythmia management. They stabilize patients awaiting cardiac ablation, and they look after a similar population of volume overload. what doesn't work for us in terms of patients? What are challenges to a successful VH admission? We obviously all want to use our resources optimally. We don't want to admit patients that we know are going to fail with us. But recognizing that some patients will end up back in the acute care environment who are under our care, and that's okay. I think if we take too well a population, then we're not really actually providing care to patients who would benefit most from our care. In terms of patients who may not do well, I think those with an uncertain clinical trajectory, where you're not really sure if they're getting better or they may be potentially worsening in that context. Patients who really have participation barriers with no additional supports. So individuals with cognitive deficits who don't have a caregiver in the home, who can't really readily follow instruction. Language barriers has become less of an issue with kind of the advent of Google Translate and translator options at this point in time. Our disposition for patients, if they don't actually have a safe place to receive care, that's a real problem for us. So we struggle with patients who are homeless. We struggle with patients who reside on the shelter system and its impermanence in terms of their having a regular place to live. If they're significantly out of zone, more than 80 kilometers out, then we often cannot provide them the full level of support. We don't want to duplicate services that are done better by another team. So if a patient can be well cared for by the outpatient IV clinic, they probably don't do well with us, right? And they're probably not best with us. Or if they can receive IV antibiotic therapy through the home IV program, again, probably not best for us. There may be other issues, for example, that we may co-manage while they're getting the HPT. And that's certainly, we've worked with that program in the past. We're a voluntary program, so if patients don't want to participate with us, they don't have to. And I think that's a key component. I think patients should be afforded choice in healthcare. Sometimes if patients require multiple IV medications over the course of the day, we don't have the capacity to provide multiple IV visits per day. We're probably limited with our resources with the community paramedics to about 2 IV visits daily per patient. So how do you send people to us? We are on Connect Care. We want you to be able to identify and assess patients according to the virtual home hospital criteria. You can order an inpatient consult to the virtual home hospital, but like any consultation, that's best followed with a direct communication with a provider who's on call, right? Oftentimes we find that sometimes the patients may have a consult placed and then are discharged, and then it falls off our work queue. So having that kind of direct liaison with the on-call physician for virtual hospital is important. And we should be available on ROCA in terms of who we are, who's on call for the service at any one time. Even a secure chat is great as well, just that direct communication. And then really, there's a collaboration that occurs, and we think about the patient being pended to admission, provided they're willing to actually be admitted to the virtual home hospital program. And very similar from the perspective of the outpatient environment. So you can place an ambulatory referral to virtual home hospital if you're seeing someone in the clinic, for example, that you think would benefit from care. And the same processes otherwise kind of apply. So once a consult has kind of been, I would say, accepted by a physician or tentatively accepted by a physician, our team will reach out and clarify that with the patient, right? We want to make sure that the patients are willing to participate. And that's not the fact that communication in healthcare is difficult sometimes, and it's troubling on occasion. And so sometimes patients' perception of what you've talked to them about may be different from once we actually kind of get down to the direct specifics of who we are and what we do. If patients consent, then we arrange for a digital remote patient monitoring kit delivery, and then we kind of walk them through the next steps of an admission to virtual home hospital, and then our team starts to take over. Our only ask of the inpatient team is that the demographics are correct, so that we know that we can get a hold of patients and their caregivers readily and easily. And if someone doesn't accept, then we would just ask you follow your conventional discharge planning processes. So what have we accomplished? So this is our data since inception from a medicine perspective. We've had over 2,000 admissions. In 2024, we admitted 528 patients to the medicine program. Our average age of patients is 71. They're with us on average for about 18 days in a home hospital environment. Sorry, median duration of 18 days, my apologies. And then we've got a fairly reasonable case mix between male and female. And if you look at the most common reasons for admission for medicine patients, it's heart failure, infections, pulmonary or respiratory conditions, and then acute kidney injury are kind of all very similar in that aspect. And then we've got a smattering of other conditions that are novel on occasion. If you look at our impact of care, these are incidence rates for the 90 days pre-EZVH for our patients during their time with the EZVH admission, and then basically in the 90 days post-EZVH. And you can see that for the most part, we seem to have an impact in terms of reducing the burden of reliance on the acute care environment for patients. That patients have less EMS activation, they have less ED returns, and they have less acute care environment hospitalization. And historically, we tend to get very good satisfaction scores from patients and caregivers that really, our satisfaction scores are that about 93% of patients are satisfied or very satisfied with the care that we provide. Caregivers feel are even greater. Providers actually also are around 90%. Do we achieve or surpass the quality of inpatient care? I would say conventional bricks and mortar inpatient care. About 86% of patients that we feel that way. And then basically caregivers are very similar. Providers less so. They feel that there may be some gaps in terms of the quality that we're able to provide. What are our ongoing opportunities and challenges? So I think we really would like to actually continue to educate and make people aware of who we are and how we work. I think we want to be really clear about eligibility criteria for people who refer to us, because I can imagine there's nothing more frustrating than going through a referral and thinking you've got a patient, then we decline them. And so not understanding that. So we want to optimize our consult and referral process. We are working with Connect Care to try to do that again at this point in time. We want to really, I need to focus on that direct communication between the VH physician and the referring physician. That conversation is so important. System integration is a challenge. Ideally, we think we can provide significant benefit if we're incorporated into kind of the strategic plan for care delivery. We would really love a new virtual home hospital specific care Connect Care build. I started this role as I said, in February of 2019, and then we knew that we were launching that coming fall, and really we didn't get any really traction until about July, and the launch occurred in November. So all of our stuff was built in the setting of about 3 months, 3 to 4 months. So it was really quite challenging. And we recognize that there's a lot of opportunity in Connect Care to potentially identify patients who can be flagged to you as a provider and say, this might be a reasonable candidate for virtual hospital. Have you considered this? Not an automatic referral, because I think referral is complex and there are nuances, but just recognizing the fact that, oh, this might be an opportunity for this patient. We really want to continue to leverage existing systems and resources. We really don't want to duplicate work, as I said, that's done better by other groups. Recognizing that we are changing culture. And that's a tough thing, right? To get us into your mindset of being an opportunity for the care of your patients. There's a lot of myths about the program. I would articulate, though, that this is going to be a component of acute care in the future of the care. I think that's well established. There's multiple jurisdictions that are interested in home hospital care, and multiple countries as well. Equitable access, I think, is key. I think it's important to recognize that the virtual hospital isn't right for every patient. We select patients who maybe actually have a socioeconomic status that makes them more successful. I think that's one of the things that I think about a lot in terms of that. How do we overcome the challenge of homeless patients to see about, or patients who struggle with other, I would say, social determinants of health? who would benefit potentially from our care. I think we want to adopt strategies that would increase eligibility. So what's in it for you? Really, I think there's an opportunity for improved patient outcomes. There's an opportunity for enhancing the continuity of care for patients. There's an opportunity for additional hospital capacity and support. And it is an opportunity to lead in one of the more interesting areas of acute care delivery in Canada. And keeping patients in their homes, I think, is always better than keeping them here. So the takeaways, I think the Edmonton Virtual Hospital is here to stay. As I said, global evidence shows that this is going to be a part of the future of acute care delivery. I would ask you to think about, are there patients or clinical conditions that you think would benefit from the virtual home hospital model of care? Are there clinical syndromes that you see on a day-to-day basis that might be an opportunity to think about providing care differently? What do you need to optimize these NVH consults? What works best for you? And how do you potentially integrate us into your patient's care plan? So I want to circle back to Mrs. A's story. So on day one of her admission to virtual home hospital, she's had some increasing shortness of breath on exertion. She would have gone home from hospital yesterday morning, and when we call her on the first day post-discharge, she has already experienced some mild PND and orthopnea. She's had about a 1.5 kilogram weight gain. She didn't actually pick up her furosemide or her medications when she left hospital, so she has missed basically probably 2 doses. And they were struggling in terms of actually just some food access in the house, so they had some takeout for lunch and supper, and instead of the 2 grams of sodium that you carefully instructed her to take on a daily basis, it's probably been about 10 times that amount. So we are able to kind of recognize that she's kind of not doing as well as on discharge, and we activate the community paramedic team to go out and see her and do a video visit with the VH physician and arrange for a Cloud DX kit to be delivered. So the community paramedics go out on day one and they do some point of care testing in terms of blood work, and recognize that she continues to be volume overloaded, but her SATs are still reasonable. And she receives a dose of intravenous furosemide and then instructions to take oral furosemide again that evening. We liaise with her pharmacy to expedite the delivery of her medications to her. And again, kind of reiterate a lot of the education that she received in hospital with regards to fluid and sodium management. And over the next couple of days, she continues to do well. She's seen regularly by the community paramedics with regular kind of consultations with the VH physician. We arrange for home care referral to assist for medication management, because that's a bit of a struggle for her and her husband that we recognize. We arrange for home collections for creatinine and electrolytes. We kind of, after the initial kind of 72 hours, we back off to about three visits per week and continue to monitor her vital signs and her weight and see that she continues to be stable on her current regimen. So between days 4 to 7, she's doing pretty well. And she is much closer to her dry weight, no new symptoms of volume overload. She's getting closer to her heart function clinic appointment. And we think that she's getting pretty close to discharge. Day 8, the wheels start to fall off the wagon a little bit. She's feeling a bit unwell. She's has some symptoms of postural hypotension. Her blood pressure's down a little bit. Her heart rate's up. Creatinine shows a bit of a bump. And we basically undertake some interventions to start her on some oral potassium supplementation. We reduce her furosemide dosing. We alter her fluid restriction parameters and then plan for some repeat assessment of her electrolytes. And the following day, we have a video call with a physician again, just to reiterate kind of what her volume status is like and how she's doing. So through the days 9 to 12, she's actually doing much better. Her lab tests seem to be heading in the right direction. She's maintaining a reasonable volume status in terms of her dry weight. We start to socialize discharge, and with her, and also, with her primary care physician. And she has that appointment pended. And then on day 13, she's discharged because we've been able to basically make sure that she's got follow-up with her PCP, her heart function clinic appointment. We provide a discharge summary and medications to both provider teams. So what are her takeaways? I would say, she actually had 2 acute healthcare changes occurring in the 2 to 3 weeks waiting for her outpatient care teams. Those health changes were kind of, I would say, caught and addressed in a timely fashion. What was the potential impact? We were able to avoid ED visits. We potentially avoided inpatient readmission. We, reduced further deterioration and potentially avoided unfavorable health outcomes for her. Kind of, there was a recognition that she may not have been managing her chronic health conditions as optimally as we would have liked. And we were able to coordinate care with her community pharmacy, home care, and then ultimately hand her off to appropriate outpatient teams who were able to provide her with ongoing continuity of care. So with us, she actually had an accessible and consistent care team. She had timely access to assessments and interventions. We were able to avoid ED visits and potential hospital readmission. And she was very happy to be able to stay at home with her husband and had a significant reduction in her anxiety about returning to the acute care environment. I do want to acknowledge the people who've worked really, really hard and supported us through our journey. So I've already outlined the benefits that Dr. Kassam and Natalie McMurtry had in terms of actually the inception of the home hospital model. Osborne and Dr. Dylan Taylor were our project sponsors, and they were invaluable in terms of actually providing support to us as a team to build this model. And they believed in us through thick and thin. And then lastly, personally, I would thank Leslie Dutra and Shelley Winton, I would say the original team that I worked with in terms of when I first came to Virtual Hospital, who've gone on to bigger and better things. But they were instrumental in kind of the foundation of care that we laid down to be able to kind of grow the virtual home hospital model. These are our contacts in terms of, myself. Laura Mummy is our project manager who's here in the audience. I think Lisa Marco is our patient care manager, and then Dr. Lara Bani is our medicine medical lead. And then we have Freddie Kay, who's our unit manager. And please feel free to reach out to us. These are members of our team. And with that, I think I'll take some questions. I don't know if there are any.
Thank you so much, Greg. That was such a great talk, and what a success story, like from 40 to like 1,000% growth in 6 years, and from 30 patients to 90 patients with those great quality indicators. Congratulations on that.
Thank you.
I will take some, or maybe we can, any questions in the room? Okay, we've got several online.
Sure. So Dr. Daniels had asked, do you get referrals for patients with lower LACE scores greater than 10, but the clinician feels the patient is high risk? I would think not, as I feel almost everyone I discharge has high LACE, but just wondering. I would say yes, we will take patients who have LACE scores less than 10, but are perceived by their clinician, their inpatient team as a high risk for readmission. And that may be simply in the context of their particular clinical environment and particular, I would say, personal or social characteristics as well.
The other question here, Greg, is family physicians. You had mentioned that we can refer from ambulatory clinics. Would those referrals to the virtual home hospital be accepted from primary care providers in the community?
Yes. Yeah, we have actually referred or accepted patients who've been identified by their primary care physician as needing support and an additional, I would say, acute care intervention directly from the community to virtual hospital. That's family medicine or family practice throughout the Edmonton zone or Edmonton area may not be as well integrated and may not have a good understanding of who we are, but those who know about us reach out to us.
And then Dr. Wong says, are you tracking how many cases need to be sent back to ED and how many of those need to be admitted?
Yes, we do. Yeah, we actually have, that's part of our performance metrics in terms of how we report to Alberta Health on the success of the program. So we look at our readmission rates and our representation rates to the emergency department. And those fluctuate over time. Year to year, they've shown consistency to some degree. And And obviously, if we see changes, we kind of think about why is that the case? Is it our patient selection? Is it something that we're doing from the perspective of care? Is it some of the resources that we actually have access to? We may be taking a sicker patient population. What's the acuity of the patients as well? So that's partly what things that we're still continuing to address on an ongoing basis. That's part of our, I would say those are part of our quality metrics.
Another comment, excellent talk, thank you. Preventive care and consistency across settings. Is the virtual home hospital providing influenza or pneumococcal vaccine, or can they? Wonderful if you prevent admission, but for some it is how they are getting immunized.
Historically, we do provide, well, I don't know if we actually provide vaccination per se. We have a conversation with patients about vaccination because we recognize that vaccinations are potentially of significant benefit for our patients. And a lot of it happens from an education perspective and identifying them in terms of the navigating the system of vaccination. What are they eligible? What do they have coverage for? What criteria do they meet? I don't think we actually have our community paramedics go out and do the immunization. We don't, to my knowledge, but we try to leverage, community pharmacies to do that where we can. We haven't, given the controversy of COVID vaccination this season in particular, we haven't really navigated that as of yet with a lot of our patients. I haven't heard anything, Laura. I don't know if you've heard anything more. Okay.
Another question here. VHH is framed as an inpatient admitting service. How do you see VHH in the context of consulting service with longitudinal inpatient follow-up, serving inpatients at hospital without said specialty services?
Yeah. I think that's actually one of the opportunities for us in the future is to think about how we might be able to support, I would say, our more peripheral hospitals that don't actually have ready access to inpatient medical subspecialties or inpatient medicine specialties. I think none of us understand what the corridor system will look like in the context of healthcare reorganization in this province. I think certainly there's an opportunity for aspects of co-management, right? With, a VH physician co-managing a patient who's admitted, let's say, to a hospital in, trying to think what would be in our corridor in Jasper. Yeah. I was going to say Hinton or Jasper. And how would we actually support them on an ongoing basis with remote virtual visits, right? With the physician. I certainly think that's an opportunity. We haven't looked at that as of yet. We're probably much more interested in the prospect of surgery for that because a large proportion of patients come for surgery, come out of the Edmonton zone,
Right.
but need to have surgical procedures done here and then go out. And so that's, I think, we've been thinking more about that from a surgical perspective rather than a medical one. But it's a very good question.
Another comment about, people with chronic bleeding requiring iron or blood support.
Yeah. So at this point in time, we don't have the ability to do transfusion support through with the mobile and with the community paramedics. They have had that opportunity in Calgary on occasion, but part of that has to do with some of how they're funded from the Tom Baker Center in particular, is my understanding. And then for us, we don't do blood product administration at this point in time. I think we could readily do albumin. That would be very low risk as a possibility, but we haven't moved there as of yet. There is interest in potentially doing that. The other piece as well, with regards to iron support, we are able to provide intravenous iron to patients as well. Our preparation is different. I'm blanking on the name. Yeah, we have to make a special authorization access application, but we are able to provide iron support to patients in the context of VH.
And can patients be sent for ongoing wound management?
Typically, we probably wouldn't take patients for direct wound management as the primary issue that we're managing. There are good supports and multiple kind of wound management programs offered through home care and then wound care clinics as well. So as a primary problem, we probably wouldn't take that patient. Would we take that patient in the context of, let's say, a diabetic foot infection who has volume overload, recovering acute kidney injury, and varying blood sugars? Yeah, that would certainly probably be in our kit and caboodle, right, so to speak, because there's a constellation of problems there that would benefit from our involvement and our team's involvement.
Hey, are you able to offer this to individuals living on reserves, and have you encountered any jurisdictional challenges in doing so?
Uh, I don't think we've actually, I don't think we've had anybody on reserve.
No, we've actually had challenges getting access.
Yes.
And then even the road quality for the paramedic trucks
Yeah.
has certain limitations. So, but that would be great.
Yeah. So just the answer, talking with Laura Mummy, our project manager, we have not been able to provide access on reserve. There are jurisdictional challenges, and just the logistics of I would say access on roads and the infrastructure to get community paramedics out in a timely fashion is also lacking at times on reserve. So we haven't generally been able to do that work.
One of the virtual home hospital pharmacists indicated that it was monopheric that
Yes.
you were looking
Yeah.
for.
Okay.
And there's one question here is, do you have any data on the average cost per patient of the inpatient stay at the virtual home hospital?
Yeah, we do. Sorry, I haven't off the top of my head. I I can't pull those numbers. We would have that from our economic analysis, but it's yeah, it's probably about 3 to 4 years old, I think, at this point in time. Oh, you know what? I can't pull the answer off the top of my head. I can actually look it up and provide it to you. One of the interesting things about our care model is because our costs are relatively fixed, as our volume goes up of care provision, our cost per patient tends to come down. So that's one of the things that we found is that, our initial care and cost per patient the first year was very high, but by year 3, we were much lower and we were quite cost effective at that time. And again, I haven't looked at the numbers recently.
Hey, well, thank you so much, Dr. Hrynchyshyn, for a great talk and informing the department about all of the great services that the virtual home hospital has to offer. Thank you.
Thank you so much. Thanks for your time.